We already have.
Thank you. Thank you. Thank you. Hello. Good afternoon. We are just at a little afternoon here. Welcome, everybody. I'm Bianca Frogner. I'm the interim chair for the Department of Family Medicine. Welcome to our Department Fair and Scholarship Forum. Yay! So as we've been doing for, I think, a couple of years now, we kick off the fair with a grand rounds. And so I'm going to just have kick us off by introducing our speakers. And then at the end, I'll be coming back around and making some remarks to really kick off the fair. But thank you to everybody who's here. Thank you to everyone online. As the day goes on, there's food back there. So please help yourself and eat it up. There's a lot of cookies back there and chips and stuff. All right, so today for our April Grand Rounds, we have the topic as seen up here, leveraging research to improve care in the WWAMI region practice and research network, or the WPRN. So it's going to be a dive into some survey-based research methods. And we have two speakers today who are faculty here in our department, primarily in our research section. We have Sebastian Tong, who is an associate professor in the department. He's a practicing physician and addiction medicine specialist. He also serves as the associate director of the WWAMI or the WPRN, and he conducts research in practice-based research, substance use, loneliness, and chronic pain. He has received funding from NIH, HRQ, I can spell those out, but I hope you all know what those are. He completed medical school at Boston University and received his master's in public health from Harvard School of Public Health, and then finished his residency training in family medicine at the Greater Lawrence Family Health Center. Then we will also have Allison Cole, who is also a family physician, a researcher, and professor in the department. She earned her medical degree at the University of Iowa and did her residency training in family medicine at the University of Iowa Hospitals and Clinics. She was a NERSA fellow, National Research, I always forget what it exactly stands for, but NERSA, I should know this. It's a very well-known training program here at University of Washington, where she also National Services Research Award. Yeah, I should know that. I really should. But this has been an important fellowship program that we've had here at University of Washington, and she also got her MPH in health services here. She's the director of the WPRN, or the WWAMI Region Practice of Research Network, and she studies implementation of evidence-based programs in primary care settings, and her research programs focus on cancer control and screening interventions and rural health equity. So please help me welcome our two speakers. This work can see. Yes.
I'm sitting, but then pulled out my back. Definitely. So here we go. So we have no disclosures. We have some funding from IHS and the NIH and from NIH Supporting Center that helps support our network as well. And so our learning objectives really are to describe the importance of primary care engagement with research, and then we thought we would do a deeper dive specifically about survey-based research methods, because I think that is an example of research that all of us can kind of engage in or think about as primary care physicians. And then so we'll look at the purpose of that and look at ways you can engage in that work as a resident or a practicing family physician or researcher. So why is family medicine research important?
Oh, sorry.
And you advancing on my.
Oh, you haven't. I thought I had to advance. Sorry.
I
can move free.
Oh, that's why it's going to file. Okay. Okay, so this is a something that was published in New England Journal of Medicine back in, I think, 2000, that looks at where people usually get care or experience health issues in the past year. So out of 1,000 people, about 800 of them have some sort of symptoms. 327 seek care in some medical setting, of which half find care in a primary care or in an outpatient office-based setting. And then we keep on going down, and what we see is that less than 1% actually get care from an academic medical center. And that's something that like it's it's less than 1 out of 1,000 people. The challenge is that most of the research we do is it just is advancing by itself.
Do you want me to override it?
Maybe you do need to advance.
I'll go back. Yes, okay.
Okay, so the challenge is that less than 1% of NIH dollars, which is the primary funder of biomedical research, goes to family medicine departments. So while family medicine sees half of people who get care in a healthcare setting or outpatient settings, we get less than 1% of research dollars. So I'll give a case example of a patient I saw in my clinic, I think 2 weeks ago. So this is a patient that I think a number of us at Harborview are familiar with. He's a 73-year-old male with a history of stroke, type 2 diabetes, hypertension, hyperlipidemia, schizoaffective disorder, and depression. So one of our common typical patients at Harborview, who comes into clinic after he was diagnosed with new onset AFib in the ED. And so in the ED, I think he was in rapid ventricular rate and was on a beta blocker. And then the question was, with his kind of risk factors, would it make sense to start him on anticoagulation? So when we look at his CAS2 VAS score, he has a score of 5, which is the score we use for those of you who aren't clinicians to look at the risk of what the risk of stroke is while being in atrial fibrillation and whether you would want to anticoagulate someone. And then the HAS-BLED score is the score we use often in clinical care to look at what someone's risk of bleeding is if they're on anticoagulation. And his HAS-BLED score is 3. So those two scores are often difficult to use because often the same things that inform risk of stroke also inform risk of bleeding. But with the CAS-VAS score of 5 versus the HAS-BLED score of 3, I think I probably, based on that score, would put him on anticoagulation. But here's some additional information in the primary care office that we knew because we know him from a long period of time. So he has a history of frequent falls. He lives actually on the 5th floor of a walkout by himself and has fallen multiple times on the stairs. There's no elevator in his building. As a loneliness researcher, I recognize that he's really pretty lonely and isolated and doesn't have a social network to check in on him. So if he fell in his apartment and bled, he could be actually just lying. He's pretty inconsistent with taking his medications because of his mental health issues and his depression. And then the actual paper was, it was actually unclear if he had a stroke or not. People had it in his chart that he had a stroke, but when you actually look back on the record, he got it fixated in his mind that he had a stroke. But there was no actually any imaging evidence that he had a stroke. And what I did look at was that how do we come up with the HAS-BLED score? It was a composite score that came about because it was a registry of patients at a bunch of cardiology centers in Europe. So it wasn't primary care based. And they recognized that social determinants of health was important to informing bleeding risk, but they didn't have that data because it was collected at a cardiology clinic. And the data they had was really biomedical in nature and not informed by kind of the experiences we all have in primary care. So that's just one example of what happens when we really focus on research in specialty settings. We don't get the information that primary care physicians have. So moving on from that, so about half of all office visits, as I mentioned, are delivered in the US in primary care. What we do with the WPRN is we really try to demonstrate that collaboration with primary care in designing and implementing research can inform priorities and then we all recognize that primary care faces existential threats in the US and that primary care physicians really just don't have time to contribute to research. But here are some reasons why we should do it anyways and how we try to make it kind of more user-friendly in the US within the WPRN. So the next slide, I think, demonstrates some of the, I stole this from Nikki. So it's from residents who were questioned about like, what do you think of? What's the first word that comes to mind when you think about research? So pain and work, it is high on the list. And then there are very few actually positive words in there. But like the word like, but I will say like some of the words I don't, like I have not sat behind a bench doing lab work ever in my research. I've never pipetted anything. So I think a lot of the things we think about traditionally as research are things that we think about from our pre-med days or our research days when we needed to have research on our resume to get into med school, right? So I think part of our goal with this talk is to kind of move away from the words like pain and evil and hierarchy to some of the words like joyful that we do see here on this. And I don't think Nikki paid anyone to put in joyful, right? Hopefully. So hopefully our talk will convince some of you that research can be really joyful and meaningful.
This is better now.
Oh,
It was 3 years ago. It's much better now.
well, I haven't seen the one more recently. So I'm so traumatized by this. So this is kind of looking at that same kind of ecology of medical care, but ecology of a family physician resident research engagement. And the reality is like thinking beyond bench work, all of us do research. Like hopefully all of us occasionally look at a journal article, whether that's an AFP. Hopefully all of us look at like open evidence or use UpToDate or these other sources that come from research and critically appraise that evidence, right? So I think there's all that, there's kind of different ways you can engage within research. I think we'll see some exemplar examples of residents who did quality improvement. And when you're evaluating the impact of that, that can be one way you can engage in research. So it doesn't have to be research with a big R that's funded by the NIH, but I think there are ways to engage in improving in a systematic way what we do in clinical practice that could be research. So I'll talk just briefly. You probably all heard me talk about what the WPRN is. It's a collaborative group of primary care practices in our WWAMI region that is committed to doing research and practice improvement. We're across about 140 practices in our 5-state region, which you can see in our map here. And it's really a whole bunch of different practices that do different types of research across our region. And that can be answering surveys, as we're going to talk more about, or that can be doing with us a randomized controlled trial. So I think it is a broad definition of what research could be. Next slide. And then recently we were also awarded an award from the NIH to really do more in-depth engagement in rural areas to look at what are research priorities in those areas. We were one of 6 hubs. We're working together with OHSU to kind of grow what rural engagement in research looks like and what priorities and what things we should be focusing on research. Next slide. So just to summarize briefly what we did so far with our Care for Health Award, we went around and listened. So that's one of the things I get to do as a researcher is I get to travel. So last Tuesday, I was in Boise doing a listening session and just talking to health system leaders and family physicians about what matters to them in their research. And then we used some community health needs assessments. We also did surveys and supported our regional research staff in going out to these different regions to do research as well. So we thought we would focus on survey-based research because I think that's an easy kind of early way to engage in research as a busy family physician. So why do survey-based research? It's one of the ways that we can easily capture information when you do interviews or focus groups, it is harder for people to participate because you need to spend an hour rather than like maybe 5 to 10 minutes answering a survey. And then I think if you're doing more in-depth research with like EHR and polling data and large national surveys or claims data, if you've ever done any of that, you probably realize how messy some of that data becomes. But survey research is an easy way to get people to fill and answer questions quickly, hopefully. So the purpose of surveys, you can understand a broader population through structured data collection. So, for example, from my patient, we can understand how many patients have atrial fibrillation in our clinic. What percentage of patients have different risks? What are kind of the correlates? And we can easily understand things like loneliness or isolation or social determinants of health by administering a survey. It can be cross-sectional, so one point of time at a given moment, or you can ask people questions longitudinally and follow them across time. So it can really capture attitudes, behaviors, experiences. We all get kind of surveys after we go see our healthcare professional. We see some of our patients fill out surveys about us, right? And their comments about us. And then we can capture preferences and also self-reported outcomes as well. So some of the strengths is it's easy to do, it's scalable, it's flexible, it can capture information that might not be available in existing sources. Sometimes when you use claims data or EHR data, it doesn't actually capture the full story, right? Like sometimes I don't want to put a diagnosis that might be stigmatizing, but I, as a clinician or the patient, probably knows they have that diagnosis, right? And it can be administered in multiple formats, so it can be online, phone, or in person. And it can include open-ended questions, but not be as time-consuming as interviews. I think some of the weaknesses, unlike some of the EHR-based or claims data, is that it's self-report. So people can like say something that's called social desirability bias, where like they may say something that they think something should be said, or they may remember things in a different way. There's also response bias. So some people may not respond because they don't want to, because of the stigma around responding. That might make surveys not representative. Often causality cannot be established. And then how we design our surveys can affect the quality of results as well.
Okay, all right, thanks. So I'm going to talk a little bit about some of the ways we have to engage in survey-based research through the WPRN. I'm going to put on my glasses. Okay, so I'm going to talk about a type of research study called a card study, which is a type of survey administered in primary care practices, and then talk about the WPRN partner panel for research, and then Sebastian is going to talk about sero surveys. Okay, so what is a card study? Card study is a term that's been around for a long time, kind of since the advent of practice-based research networks. And it came from actual physical index cards that clinicians would keep in their pocket and complete during patient encounters as a way to gather data about clinical care. And the idea behind this is that it's a type of survey that is done quickly, should take less than a minute to complete. And clinicians can fill it out to describe clinical encounters, or office staff can fill it out, or even patients or families. And even though it's a relatively simple strategy for gathering data, it has actually made meaningful contributions to standards of care in conditions like headache, spontaneous abortion, and treatment of otitis media, as well as many others. And sometimes it can even help you better understand outcomes that you're seeing in your electronic health record data, because it gives you a little bit different perspective on health outcomes that you're measuring. So what are some examples of questions, research questions that you can ask with a card study? So for example, you could try to explore what the estimated prevalence of a condition is, or what are the characteristics of patients who have a condition. So you might ask clinicians to complete a card every time they see a patient with hypertension, and then fill out some brief information about is the patient smoking cigarettes? Are they drinking alcohol? Do they exercise? Whatever variables you're interested in. It can also be a way to assess feasibility for future research. So if you are planning on conducting a clinical trial or other type of study where you might need to enroll patients, It's a way to capture a little bit of information about how many patients there are with a specific condition. And then you can start to explore outcomes or how well a disease is being managed or controlled in a given population. So I'm going to give a summary of a card study we did in the WPRN a number of years ago, more than 10 years ago now, that was patient preferences for weight loss programs, WPRN card study. So at the time this study was developed, we developed it in partnership with clinicians in the WPRN to really work directly with clinicians to say, let's use a card study methodology, help us get some experience with this approach and answer a question that's important to clinicians who are in practice. And at the time, there was a new U.S. Preventative Services Task Force recommendation that adults be screened for obesity with a body mass index in primary care. And then if they had a BMI of over 30 or greater than or equal to 30, they should be referred to or directly offered comprehensive weight loss programs. And the comprehensive weight loss programs had a bunch of different components, but it was basically an intensive multi-component behavioral intervention that included one-on-one support and education and helping with motivational interviewing. So this new recommendation had come out from USPSTF, and clinicians were interested in what the prevalence of obesity was in their clinical practice and how interested patients who might meet this threshold of obesity would be in participating in these programs, with the idea that they might think about how to increase the availability of programs like this in their communities. So the goals of this study were to determine how likely overweight and obese adults are to participate in a comprehensive weight loss program as recommended by the USPSTF, and then start to explore what might influence patients' self-reported likelihood of participation. So this, again, was a card study. It was a brief one-page survey that was administered to patients. It was offered to all patients who were 18 or older, excluding pregnant people. And it was administered over a 2-week period in 2013. And each clinic that participated had a stack of the survey instruments at their front desk. And when the patient checked in, the front desk person handed the patient the survey. The patient filled it out in the waiting room and then returned it anonymously to a return box in the clinic. So we had 12 primary care clinics in the WPRN participate in this study. It was offered in both English and Spanish, and the data was collected anonymously, which meant that it was IRB exempt. So this is just some photographs from the survey in the field, so that it was like a little booklet that was yellow, and you can see that is one of the clinics. We did a site visit where they participated, and they had the return box, like return your survey here. And then this opened up, and this is the questions that they answered. So it was all self-report. And then they returned the survey into the box, and then the WPRN team collected all those surveys. Primarily, the clinics scanned and emailed the handwritten surveys to our team for data entry. So what did we find? So we actually received 1,977 surveys, which is a relatively large number of surveys for a primary care study. 14 people were excluded because they were actually under 18, even though we had instructed people under 18 not to complete the survey. And then we excluded another 30 surveys because they didn't answer our key outcome questions, so they were incomplete. So that left a little over 1,900 included in our analysis. And this just shows the variation in the number of surveys that were returned by the clinics that participated. So this is actually only 11 of the 12 studies or 12 sites that participated, but one clinic had 33 people return a survey over the course of 2 weeks, and another clinic had 382 people return a survey over the course of 2 weeks. So you can see this reflects probably a lot of things. The patient volume in the clinics, some of our clinics are really small and might have had single provider days or relatively small volumes of patients seen. Some of our clinics might have had variable implementation where they were supposed to be giving the survey to everybody who checked in, but maybe they didn't do that consistently. So that led to a lower number of responses. And we tried to estimate the participation rate by asking the clinics to report the number of adult patients that they would see in an average 2-week period, and then calculated the response rate based on the number of return surveys. So you can see some variation in the response rate using that kind of rough measure there. In terms of the actual results, we found that this is again self-reported data. So there's some differences in using self-reported data to estimate BMI as opposed to data that's captured in the EHR. But you can see that about 33% were either underweight or normal weight, and the remainder were either overweight or obese. And then we looked at whether people who met criteria for overweight and obesity would be willing to take part in a weight loss program as described by the USPSTF. And most people, 90%, said they would be at least willing to consider taking part in the program. And 34% said they would very likely take part in the program. And then we had asked a question of the people during the survey, like, do you think your doctor would advise you to lose weight, as a way for us to try to get a sample of people who are medically maybe more appropriate for weight loss, and ask them to think about what would help them decide about whether to take part in a comprehensive weight loss program. And some of the most important factors were thinking, learning about the program not costing much, making sure it's convenient at a good time of day for me, and easy to get to. So in summary, we found that over half of respondents either probably or very likely would take part in a comprehensive weight loss program, and that cost, location, and time of day were important factors in helping people decide whether to take part. And so this study was a really fun and interesting study to do in our network, because we got a lot of clinics involved, we got a lot of data, and each of the clinics got their own report back about their patients, and were able to use that to think about how to care for the patient population. So it was a really neat experience to do, and I think led to some meaningful clinical changes. All right, I'll turn it back over to Sebastian.
I think this is you.
Oh, no.
Oh,
yeah.
You want me to talk about this?
Go for it.
Sure.
Yeah.
Okay. So we also have a mechanism within our WPRN that is looking more directly at what our providers' experiences, what our clinicians' experiences. So we have a group within our WPRN who agree to occasionally get solicited basically for surveys or for qualitative interviews. And we basically try to be responsive to requests from investigators to give input for primary care physicians from primary care physicians to inform kind of study design or to do some preliminary work as the co-designing studies and grant proposals. So we have what we call the PPR, and the membership is basically based on clinicians from our WPRN. We solicit from our champions, we solicit at some of our meetings in the region. So we were at, for example, the Idaho Academy of Family Physicians and the Alaska Academy of Family Physicians meetings, and we asked people if they were willing to join, and occasionally get emails about specific surveys and topics. We send out about a maximum 5 a year. So we have 120 individuals within our roster right now. The majority of them, as you can see, are physicians, MDs, or DOs, but we have a good selection of people who are PAs and NPs, PharmDs, PhD psychologists and social workers, and a smattering of people across the 5 states. I think fairly proportional to the actual populations relatively of the different states, and a different mix of race and ethnicity as well. So the way it works with our survey research panel is that surveys must be pretty short. They should be 5 to 10 questions long, distributed electronically, and offer some incentive payment to people who complete them, recognizing that clinicians' time are really valuable, so they are more likely to complete a survey that is incentivized in nature. And they must also be IRB approved. We actually charge the investigator a small fee to help administer the survey and pay for the infrastructure of the work we do. And what we do is our coordinating center, so that's me and Allison and 3 of our research staff, that each survey. And then we also have a larger steering committee that is made up of participants from across our 5 states. That's both people in health system leadership like CMOs, behavioral health professionals, pharmacists, family physicians. I think we have someone who works in an insurance company. So a group of different people that and provide feedback and approve potential projects. And we actually really enjoy doing that work. We meet monthly. We actually met this morning. This hugely robust discussion of all the different projects that they're vetting. And then what happens is then after it's vetted, if there's any feedback, that goes back to the investigator for change, if any. And then we administer the survey and send it out. And then the PI who gets the survey responses directly shares a summary of them with us after a few months. And we do no more than 5 projects a year like this so that we don't overwhelm people on the panel. Next, great. So here's an example of some of the studies we've done. So they really range from cancer screening to bias to chronic pain and PTSD to a whole range of different topics that we see in primary care. And I'll go in detail a bit about one of the topics we asked about in 2024, which was prioritizing behavioral health topics in primary care. So here we asked clinicians as we were preparing for an AHRQ grant on what they prefer to focus on in behavioral health topics and what they like for quality improvement approaches. So the 5 questions we had, the top one was, what is your highest behavioral health priority for quality improvement? What do you need help with most? The second one was looking at strategies for quality improvement and what would be most useful to your practice. Like, do you want practice facilitation? Do you want data back in your EMR? Do you want learning collaborative group meetings to learn from other people? And then the third one was looking at, does your clinic currently have any integrated behavioral health and what does that look like? And then the fourth one was any other thoughts that open-ended in nature as well. So with those 120 participants, we had 41 respondents. The top priority to address was around depression and anxiety. It was a field. And then the second one was loneliness and social isolation was the second topic that was identified. And we had a number of other topics that were not ranked highly after that. And in terms of QI support, a lot of people wanted to see workforce training and support. So how do we train our existing workforce, recognizing that there are a lot of workforce shortages in our region. And then they wanted practice facilitation of coaching. So that's helping practices through a period of time set goals and kind of work with the practices directly to facilitate quality improvement. People are interested in learning collaboratives. That's a practice where we work with practices together so that they learn from each other, and different people learn at different stages, help mentor other people as well. And then there may or may not be a facilitated kind of presentation with classrooms as well. People are interested in IT technical assistance, and then other shared learning opportunities as well. So that is the PPR that we administer. So if anyone has questions about that and is potentially interested in doing a project like that, Allison and I are happy to answer questions. We are able to send that out if you're interested in kind of a broader WWAMI project and getting perspectives of different clinicians. The last survey opportunity I want to talk about is a CR survey, which is administered nationally and is sent out. It's called the Council of Academic Family Medicine, which makes it the C, Educational Research Alliance. And it's basically a framework to help organize a lot of the educational surveys we see out in family medicine. So I think surveys are sent out annually or sometimes twice annually to program directors, to clerkship directors, to department chairs, and to all of you, to general membership as well. So you may, if you're a member of the Society of Teachers of Family Medicine or AFP or NAPQA, have seen some of these surveys in the past. And the process that happens is that you submit a proposal with a proposed survey and then with some background and rationale. The proposals are peer reviewed by other people in family medicine. and then specific applicants are chosen to move forward and assigned a mentor. And then what happens is they administer the survey for you centrally. So after you refine your survey if you're chosen, it magically gets administered, and about 3 months later, you get results, the Excel sheet that you get to analyze. And then you publish and present the results. And actually, if you're interested in doing data analysis and want to look at other people's results, you can write up papers on other people's survey results that they haven't been up on. For example, they then publish after 3 to 6 months all their data publicly. And in the past, I was able to do a secondary data analysis on something they had not analyzed in the data set before about maternity care. So that is something you can do and publish on other people's survey questions. I'm kind of jumping around, sorry, because it just occurred to me. And you can use that data and get a publication out of it if you're interested in doing secondary data analysis on existing results. But anyways, I'm going to give you an example of a survey I did 10 years ago that I am now doing a follow-up on. So 10 years ago in 2015, I guess that's 11 years ago, that makes me feel quite old. I was interested in looking at addiction medicine curriculum in family medicine residency programs. So I proposed a survey that looked at whether a program has a addiction medicine curriculum, and then also the outcomes from that as well. So the pre was actually in 2016, we published it in 2017, and at that time you can see that less than half, I think it was 28% of programs had a required addiction medicine curriculum. I think our response rate was about 50% to that survey. And then I worked with some colleagues at Jefferson and Tufts recently. They proposed a survey and reached out to me saying, hey, you did the survey 10 years ago. Do you want to work with us now? So I met some new colleagues and even had dinner with one of them when I was in Philadelphia recently. So got to meet some new colleagues through research, and we repeated this survey with some new questions. And then we found that right now it's, I think, close to 70% of family medicine residencies have an addiction medicine curriculum somewhere. And we had, again, like I think about a 50% response rate, which is a pretty good response rate for survey research. Joey, I hope you were in the yes, I responded category, not the no. Next slide. So some of the other things we explored was what settings do people have experience in with addiction medicine. So I think in the past it was mostly classroom-based activities, and it was about 20%. Now it's still mostly some classroom-based, but it's also a lot more addiction treatment in a primary care office. So we're seeing that within the scope of family medicine practice. And so there was actually change in a positive direction, so more exposure in all settings, except for the inpatient psychiatric hospital, which is probably makes sense that we're not sending more people to inpatient psych hospitals for experiences about addiction, since most of us don't practice in those settings. Next slide. And then this was in the past 3 years, how many of your graduates from your program have pursued fellowship training in addiction medicine? 0 was 2016 and 1 is 2026. And we are seeing a few more. Like still, most people answered 0, but we are seeing more programs that have 1 or 2 residents go into fellowship training afterwards as well. And then one of the questions we asked is, from your perspective, what are the top 3 barriers to improving addiction medicine training at your residency program? I think before we saw that it was some substantial amount of lack of resident interest that has declined, lack of faculty time to prepare curriculum. So I think a lot of faculty can probably resonate with that. That continues to be a problem, actually it's increasing, unfortunately. And then lack of faculty expertise is actually decreasing, and lack of faculty interest is also decreasing. And then the other big area we saw was inadequate institutional support. So from like the C-suite or higher leadership beyond just the faculty and residency program itself. So that's an example of something you can do if you're interested in surveying. In this case, it was residency program directors, but you can propose something that is for for clerkship directors, if you're interested in medicine education, for department chairs. A recent one from department chairs that came out in my area of interest was like the loneliness of the department chair. And how, and I see that as like, people have like a 3-chair gap between Bianca and everyone else. And like, what is going on? I was thinking that it made me think of that Sierra survey. So that was an interesting survey that maybe Paul, you responded to, I don't know, or maybe you didn't, you were one of the non-responders, right? So if you want to see what your department chair thinks, or general membership of SCFM and NACWAG and the other family medicine organizations, those are surveys you can submit and then get a lot of feedback on from a mentor and from reviewers as well. So I'm happy to answer questions about that specific survey type. Amanda's on the steering committee, so you can also talk to Amanda and let him, she probably knows more than I do about those surveys. So to close off, how to do a survey. I think the first thing to think about is like, what is the research question you're trying to answer? So I think all of us, whether we think about it or not, do have research questions, right? Like I think about just like the past few clinic sessions I was in, there are things we don't know what to do or where the evidence doesn't apply. And it's often because it's something that's uniquely family medicine, where there's no answer, or it's like a problem where there's a social determinant of health, or it's multi-morbidity, when those people were excluded from other studies as well. So thinking about that, thinking about the survey purpose and methods we reviewed, how can you, is this a question you can explore further with a survey? And that could be like, you could do a, like, we gave an example of a card study where we had almost 2,000 responses, right? You could make a card and hand it out to the next 10 patients you see, for example, right? And think it's just pilot that and see what responses you get. So defining a specific objective, what you want to find out, the population you'll collect surveys from, and then how will you collect the survey? I think handing out cards is an easy, old-fashioned way. The challenge is then you have to input that data into a spreadsheet, right? Whereas if you hand out that iPad, you may use the iPad, but you will have that data in a spreadsheet on a Mac. In terms of survey questions, I think there's something to be said about using validated survey questions when available. Sometimes what we're looking for doesn't have anything that's validated. But then the response options, I think, thinking about like, is the question leading in some way? How can I redefine it so it's not? And then there's a whole bunch of different response options that you can use, ranging from yes, no, which is the easiest, to frequency, numeric scales, Likert scales, or open-ended questions. But then the question is, who is looking and meeting all the open-ended questions? And then I always advise pilot testing your questions with a small group, because someone is going to catch a mistake that like you stared at it 10 times, but you didn't catch it, but someone will catch some double negative that you didn't intend or something, right? So it's good to pilot test your questions. And that is it. So we're open to questions and open to helping you design surveys as well. Thank you, everyone.
To help the question, but I think Mari might have questions.
Yeah, is there, if there's online questions, let me know. No, okay.
We don't have a microphone to pass around, so you're going to have to just speak up really loud and probably repeat the questions probably for the folks online.
Okay.
Any questions for our speakers?
That was great. Thank you. Learned so much from that. Family medicine, mostly emerging care. In that way. So with Epic Cosmos, is that something we could use? I mean, you mentioned that like Epic doesn't really capture the information, but I feel like the stuff that's in there is just not, it's just kind of ill-defined, right? But now that like potentially AI can kind of take all, I mean, look at the bridge, right? It's sometimes hallucinating, but most of the time it's working well. Is there like is that something that UW is participating in with Epic Cosmos and then for the primary care point? I don't know. Maybe could you repeat the question?
Go ahead. Thank you. The question is whether Epic Cosmos or other Epic tools at UW or other places might be useful in research or gathering data. And I don't have any personal experience with Epic Cosmos. I actually don't. even know if I exactly understand what that term means, so I'm probably the wrong person to answer it. But
I think there's a whole group of emerging research that's looking at, can we basically use AI to capture words and notes? Whereas I think before we had to use data that was in kind of standardized data fields where you click a box and you clinicians chose something with that drop box, right? So I think that's an emerging area of research that I think is to be defined and potentially that I think practice-based research could contribute to.
Mhm.
And could make research easier for the average clinician to say that.
yeah,
That makes my easy. Okay, I see Dan over there.
Thank you. That was a very clear explanation of what you're doing. It all makes really good sense. I'm glad this is available, a resource continuing to be available. I'm curious, I know that the Roman research practices have been in existence for quite a while. I'm wondering, what are the trends these days in terms of what are the challenges you're finding, or are things going better with the practices? How have things changed in that realm?
I think it's one.
Can you
So the question is like kind of the trends in the WPRN and kind of research engagement. Is that kind of answering your question, Dan?
Yeah.
Thanks for asking that. I think one of the reasons why we describe with PPR, why we have done the PPR and done that is because there is a desire, I think, among some clinicians to engage in research. But since a lot of practices are being bought out by larger health systems, they may not be in a situation where their health system supports them engaging in research. So responding to surveys or responding to engaging in qualitative interviews is a way for them to do that type of work. So I think there's definitely that kind of growing trend of what are the larger kind of C-suite institutional barriers to research. I think there's ongoing concern about kind of just the overwork and workload burden on primary care clinicians that affects ability to participate in things that is beyond the next patient that they're seeing or the urgent phone call. But I also think there are hopeful signs as well beyond all the doom and gloom, right? Like I think there's like a huge push to kind of look at what we can do to bring back joy in family medicine, and that's a focus of research, I think, for some people. And I think potentially from AI, we can look at things that reduce administrative burden on physicians. So that's an area that's emerging. How do we look at that to help physicians in their day-to-day tasks in a way that the EHR that was that great promise didn't do that, right? So I think there are some signs of hope as well.
I have a question for you.
Yeah.
How do you think of QI relative to research? And what's the difference, and maybe what are the IRB implications of the difference? You pointed out QI as part of your talk, but how is that similar or different than research? Or how does it relate?
I think
that's a whole topic.
Yes.
Sure. I think that's a whole topic in itself, but I think that's really good to distinguish between what is QI, what you need an IRB for research. I think of QI as something you're doing in your own practice, applied to local contexts, or your own health system, to improve the care of the patients you're taking care of. Because often it's about identifying need that you find or that your patients saw, your staff members saw. I think of research as something that's like, then you take a step further, it's like, how do we apply that to other contexts? How do we make this generalizable beyond our context? How is what's happening in my local context from QI able to be applied and adapted to other contexts? So that's when I think often you need a institutional review board to look at, like, is what you're doing ethical, right? Like, are there concerns about data security because you're going beyond one specific institution? Are there concerns about whether what you're doing is that what is that equitable? Is that fair to other participants, etc. Things like that. I think we often think about need an IRB when we want to publish something, because that's a requirement often when you submit a manuscript somewhere. I will say an exception to that is if you want to write for a section in Annals of Family Medicine called Innovations in Primary Care, we do accept like 500, 600 word. Hey, I did this cool thing in QI in my clinic, and I just wanted to describe it. So you don't need an IRB for something like that or a narrative essay, but you do whenever it's a research article in a journal.
And maybe I'll just add that the UW has a lot of great tools for helping figure out is the question I'm asking and the strategy I'm thinking about using research or quality improvement or something else entirely. So the UW HSD Human Subjects Division website is a great resource. The research section and our teams have a lot of experience thinking about those questions. So we would hate for anyone to go off course one direction or the other. And I think there's a lot of good information out there.
Other questions from the audience? We still have a little bit of time. There you go.
I have a question, but I wanted to give a Sierra, since we got a Sierra shout out. So here's, I've sat on the Sierra board for like 5 years now, the steering committee. So here's my like 3 take-home points for Sierra. Don't bother applying to the program director survey. It is very competitive unless you're Sebastian. It's awesome. Unlikely to get accepted, but not Sierra. Apply to the chair survey. People don't want to survey the chairs, and I don't know why. I have like good information. Apply to the clerkship director survey. Some years we had 6 proposals and took 5 of them. So unless yours was really like illegible, we were probably going to take it. So see, and if you have any questions about how it works, let me know. And then the other thing I'll say about the secondary data analysis, this is an unrecognized, untapped, like kind of place of data. And it's not just that you can do secondary data analysis of one person's survey. The way Sierra works is that they put together 5 topics in each survey. So what you can do is take questions from survey A and questions from survey B and do this cross-sectional analysis that probably has not been done because the original survey people never intended it to be that way. So if you have questions about how to do this, it's a super cool thing. If you're a trainee and you want a project and you don't want to like have to do the pain and the work involved, it's already there, and you are going to have to like maybe do some stats about that. But it's way, way easier. And there are some really cool potential things that you could do. So yes, do Sierra, don't apply to the ones you won't get accepted to, and go and find your data for sure.
Don't do what I did, is what Amanda said.
Really, it's just because there are so many grants to the programs, and because it will have to do scholarships, and because you're in residency, you're like, well, I'll just do the program directors because I want to have a residency question. But you're competing against like 500, 600 other programs across the country who all have equally good ideas to you, and they can only take 5. So they will use or 10. They will usually see like 20 or 30 or maybe even 40 submissions for those slots. Whereas again, there have been years where we have like wandered around trying to find someone who wanted to ask chairs questions. So if you have questions about chairs or clerkships, then do that.
I will say the secondary data analysis it did was actually across 2 surveys that were in the same cohort. I think one asked about group medical visits and the other asked about prenatal care. And we combined them to kind of make something about group prenatal care. So very doable.
Yeah, I have one for you, which is, so you say just go ahead and pilot some questions. Is there a good starting place to think about what questions you should even start with? Like, is there like a data bank of questions that one can go to, or how would you even start with trying to think about what kind of questions to ask?
I think using OpenAI is a good place to start to see like, or just doing a brief lit review is a good place to start to see what has been done out there before. I think the other thing to think about in terms of like if you look at the basic demographic questions, there's often like a common data element set that NIH has, and they have, I think, also the Phoenix toolkit, PHENX toolkit, which has some baseline commonly used surveys, and validated survey instruments that we can pull from as well.
Emily.
Right, if there's no other questions?
I think Emily had one.
I thought that someone already asked this question, and thank you for an informative presentation. I was intrigued by your word cloud, and part of what makes research hard and evil is it's not really just about putting together a survey and sending it into Stera. It's really about having a team together and finding people with the expertise, to fill out those dreadful IRB applications, to do the recap, to put the survey in, to be able to manage the data, download and analyze it, and so like, how does a resident or someone who's not in the research space sort of feasibly kind of have all that together so they can do the survey they want to do?
Nikki?
Talk to Becky.
Yes.
She was just hugging Rachel.
Oh.
All her hard work. Yeah.
So, identify a lot of like high school students or other college students pretty much were like super eager, but they're preclinical, so you can only do with them so much, right? So they kind of fall in. But I find that they're great at stuff like that. So once you kind of take on the format, you're like, okay, now you have OpenAI, because don't put anything